So symptomatic versus asymptomatic matters. The degree of severity of their vital signs. Because you could have a heart rate of 135, feel lightheaded, but not be critical, but you could be unstable, right? Now, if you have a heart rate of 180 and you are unconscious, symptom, and a blood pressure of 60 over 40, is it more than unstable? It'd be critical, right? And if you respond to, so if we stop your, not stop, but we stop to take a cardio, we cardiovert you, put you into basically back into normal sinus rhythm, are you in shock? We shock you, you wake up and say, damn, that hurt. And your blood pressure's 100 over 60. And you're like, what they're at, and the person's asking, what did you do to me? I will ask you again, are they in shock? No, not in shock. So, just, oh good, it gets the whole board. So to start, let's talk about what shock means. So think about it this way. Let's start here. If you've heard it said, like somebody loses a couple of family members in a tragic accident and they're in shock, right? What does that person look like? If we say, oh, she's in shock or he's in shock, what would you?
Pale.
Pale? Maybe.
Anxious.
But perhaps, or possibly, catatonic, right? You've seen someone who's had a tragedy happen and they are just, right? And we say they're in shock. Are they able to take care of themselves in that moment?
No.
No. So shock, technically defined, and even using that as an example, it's a poor example, but it kind of gets us started, is when you're at a condition in which you cannot meet metabolic demands. I don't know how Miss Rogers or Miss McCauley defined it for you, but where your body or your state of being cannot meet metabolic demands. So this individual who we see as catatonic and we say they're in shock, they're viable, they've got a good blood pressure and all of that, but they don't feel like, they don't even have the drive to think about eating. You know, they wouldn't think about going to the grocery store. They wouldn't think about doing the things. They might even forget that they need to go to the bathroom until hours later, and they're like, oh, I got to go, right? Okay, so we want to be a little more concrete than that. Something I want to ask you is, do you have with you or available to at your fingertips the document? Well, I had it here. The document, the piece of paper that you have from the exercise you have from Code Blue Day that has all the medicines on it. Looks kind of like this. You have that with you?
I have like a lot of pages printed off.
Okay, so if whoever has whatever part of that you've got, pull it out. Because what I want to do is begin to draw a connection. Last week we talked about a lot of numbers and the relationship of the numbers. Why do we care about those numbers? SVR, cardiac output, cardiac index, pulmonary capillary wedge pressure, CVP. Why do we even care about those numbers? Why do we care? Okay, we want to know what we want to know how efficiently their heart's beating. What else? Okay, we want to know what systemic pressures look like, central pressures look like. But more than that, why? Not everybody that everybody cared for today had a SWAN. Okay, to get at criticality. No, I don't need it. You need it.
Oh.
I've got one.
Okay.
So hemodynamics here. Dynamics,
Yeah, how
Tell-
much oxygen?
that's definitely a part of it, right? Hemodynamics point to criticality, they point to stability. Right? Hemodynamics, those numbers tell us in tangible ways and sometimes softer ways how our patient's doing, how stable or unstable they are. Right? A swan is just a specific instrument for a specific situation or population. Right? Why do hearts get swans, but not everybody gets swans? Well, not everybody's got heart damage. That's true. But we used to put swans in everybody that was septic. If they were coming up to septic shock, we'd put a swan in them. We've since quit doing that. So why do we just do it with the hearts? There's kind of an obvious. Don't overthink it. Not infection. It's not about infection.
You want to measure like at the site where
Where,
they're sick.
well, where we've traumatized, right? What did we do? So you guys watched today. What did we do to those people who, before they were day of surgery, right? So they came in today. They were electives. Was it inpatient?
Yeah, but I didn't think that's
Came yesterday. What about yours?
I'm not sure, I know who's ahead.
Okay, so last week they're walking, talking, shopping at Walmart, right? Enjoying Associates Week. In case you didn't know, Associates Week, there's 6,000 or so people from Walmart around the world. Not the week to go to Walmart. Found that out Friday. I mean, busloads. Anyway, all right. So what did we do to that person?
their heart.
We stopped their heart from beating, not a run-of-the-mill event, right? And we not only stopped their heart from beating, we also cut into their aorta, cut into their their carotid coronary arteries, and sewed in new stuff, and then jump-started their heart again. So pretty good indication to put a device in there and monitor what the heart does, right? I mean, think about Brenda's patient from last week. If you put your thumb through somebody's ventricle, wouldn't you like to measure from inside? Heck yeah. Okay. So those situations create an opportunity for us to put a Swan-Ganz catheter directly inside their heart. They are not high yield for other conditions like neurogenic shock, cardiogenic shock, anaphylactic, or whatever. Okay. So, but they give us a guide. So the other thing they do is they give us a guide to treatment. Right? Now, our Swan-Ganz catheter is only hemodynamics we have. No. Right? Did we talk about hemodynamics in adult 1? Did I ever mention Swan-Ganz catheter? No. So we talked about, so hemodynamics is not limited to just what comes out of a Swan-Ganz catheter. Okay? So let's do this. Let's talk about shock states. So what kind of shock states are you going to be tested over?
Septic, cardiogenic, neurogenic, obstructive.
Okay, neurogenic. What else did you say? Okay. What else?
Obstructive.
And we will put distributive up here, right? And there's one more that's missing. Yep, and was anaphylactic, I think it's included in distributive, isn't it?
Yes.
So we'll put it here. Okay. So we have these forms of shock, right? Now, I want you to tell me a phrase that you heard probably 1,000 times during adult 1.
Turn, cough, debrief.
Turn off, debrief. Oh, fair enough. Something else. I know we talked about it in both SIMs. We talked about prioritization. We talked about it in the pulmonary section. We talked about different pulmonary problems.
ABCs?
Well, yeah, it's more of a phrase, like
Okay.
like a catchphrase. Huh?
Treat the cause.
Treat the cause. And what else?
Not the symptom,
Manage
manage the symptom.
the symptoms. Okay? Heard that a few thousand times, correct? All right. So we have several different types of shock. What do they all share? When we talk about these things producing shock, what do they all have in common?
The heart.
Maybe. It's on the board. Huh? Yes, hemodynamics, and hemodynamics to what degree? Right? So for whatever reason, this problem has created a situation where they cannot meet metabolic demands. Okay? So we'll start right here with a simple example. How does a bee sting produce anaphylactic shock? What'd you say just a minute ago? When we were asking about phrases. What'd you say?
I don't remember.
A, B, C's.
Oh,
Right?
yeah.
Right? Because what happens if somebody has anaphylaxis in response to a bee sting? Airway closes, right? That's the problem. So, the way a bee sting produces anaphylactic shock is the airway occludes to the degree that they cannot breathe. If you cannot breathe, can you meet metabolic demands?
No.
No. So, what is the treatment for that? Okay, epinephrine. IV and or IM and or inhaled. Okay. So what's the difference between IV and IM distribution of epinephrine? IV's faster. So do we really want to try IM administration? No. Okay. But since you just spurted it out there, I thought I'd put it up there. Now, which is faster, inhalation or IV? Inhalation. Right? Have any of you ever used or seen somebody use albuterol? When does it take effect? Right after they inhale it. Right? A lot of vasculature in the surface area of the lung. Right? And racemic epi can be inhaled. Right? So we could do both. If it's severe enough, we could do both of these. What is our hemodynamic what is our value that tells you we're in shock in this case? It's not necessarily a hemodynamic value, but it's a number. O2, right? O2 is our number. Now, if we persist and left untreated, we're going to see blood pressure drop, right? Initially, when this patient is terrified because their airway's swelling up, what's their heart rate and blood pressure going to do? You know what? Do we want to give them a medication like nitroglycerin or a calcium channel blocker or a beta blocker to address their heart rate and their blood pressure? Oh, hell no. Right? Is that fixing the problem? That's attempting to manage symptoms, but that's not the effect, right? That's not what you want, because what is going to happen when you do treat the problem? They're going to bottom out. Okay? So with this, you might expect to see initially elevated heart rate, elevated blood pressure, right? But wait a minute, Mr. Hart, you said the treatment is to give epi. No,
Wait for dilates, busy dilates.
exactly. Right? Epi is the antidote to an anaphylactic response in our system. That is what we release to combat that. So once we get, why is the heart rate, blood pressure up? Not to compensate, because they're terrified from the lack of oxygen, right? That's why their blood pressure and heart rate's up. They need epinephrine in order to combat the anaphylactic response. Does this make sense?
Mm-hmm.
Right? So we're treating the problem, not managing this heart rate and blood pressure. It's, when you think about, wait a minute, beta 1, beta 2, that's going to increase heart rate. Yes, beta 1 will increase heart rate. What does beta 2 do, though? In the lungs? Dilates, bronchodilates. So that's why we want epi in there fast. And why inhaled might even be better, right? If we can do that. Now, when you think about, so I've had this patient who came to our EP clinic because she had long QT syndrome. It's kind of a funny story. I mean, aside from the suffocating part. But, so she was 14. She goes to Six Flags in St. Louis with a church group. And she's there, they have all the flowers. So she's looking at flowers, zap, bee sting. Anaphylaxis from the bee sting. Okay, here come the paramedics who are on at Six Flags or out in the parking lot or wherever they are. So they run up and they're like, oh, we're going to fix this. Now, paramedics are not going to have epinephrine breathing treatments. They're not going to have that suspension in their trucks. They're not going to use it often enough. Okay, so they give her epi, and so in response to the epi, she goes into VTAC because she had long QT. Nobody knew it. But do you have to treat the suffocation? Yes, you've got to treat the airway, because ABC, the airway and breathing will kill you, right? So she was stable in her VTAC, and once the epi kind of faded off and they got her to the hospital, they gave her some Benadryl in the truck and that sort of thing, like 75 or 100 milligrams of Benadryl in the truck. So by the time we get to the hospital, they don't have to give her more epi. The VTAC stops, and then do a 12-week EKG, and you've got long QT syndrome, and that's why you had VTAC. So, but that story, it also illustrates how you prioritize, right? The VTAC's a problem, but the VTAC showed up after the bee sting. We've got it in response to the epi, but we've got to treat the airway. Okay, make sense? Okay, so that's anaphylactic. All right. There's another one up here that we have talked about that will directly affect hemodynamics, and that is hypovolemic shock. We've talked about this one before, right? This was like first unit. So y'all should have this one mastered, right? What are the possibilities? You've got two types of hypovolemic shock. Excellent. So you can have hemorrhagic or non-hemorrhagic. Okay, first question. If you have hemorrhagic or non-hemorrhagic shock and you are a paramedic, what's your first treatment? Be more specific. Okay. So, first would be NS, and that's particularly for a paramedic, not in a hospital, right? No blood bank available, no cross match for blood, right? Okay. So, you are in a hospital. You have an Omnicell, you have done initial lab work, and your patient's blood pressure is 60 over 30. They are unconscious, no level of consciousness. Their heart rate is 155. Stable, unstable, or critical. I would call this critical. If they're unconscious, could you call it shock? Okay. This would be a good picture for hypovolemic shock. Okay. You're in the hospital and you're holding the guy's arm, not attached to his body, because the paramedics brought it in with him. You might need this. Okay. But you're in the hospital. So what's your first treatment? I'm going to put hospital right here. So for hemorrhagic, you're in the hospital. He's been cross-matched. So Brenda, tell us about your patient today.
She had a baby 2 months ago, and she came in because she was having some postpartum bleeding. Her clots were this, literally not even exaggerating, they were like this big.
Do you realize from here to here, your hands got farther apart?
Yeah.
They were this.
They were.
They were this
They
big.
were huge. Anyways, her blood pressure went from 110 to 67 over like 48 maybe, like that. And she already had fluids. She was alert when she was talking to us a little bit. But she had to get a blood transfusion like right away. So
And y'all gave O negative, right?
yes. Negative.
Which is the hurry up blood transfusion.
Yeah.
Now, they didn't use the rapid transfuser, which they could have, but usually for one unit, they don't. For here, if it is a patient who, like that, acutely comes in, they left 3 pints of blood out in the ditch, and they've got a tourniquet on the guy's arm, and they're literally handing you the arm, and you hook him up, and his blood pressure is 60/30, you're going to do a rapid transfuser with 3 units of O negative blood. You're not going to get a cross match. You're going to call the blood bank, say we need some O negative, and as soon as it gets here, you're going to transfuse it. Because what's the problem?
Not enough blood.
Blood loss. What's the solution? Blood give, right? Do we start fluids? Sure. Like in this case, before she dropped her pressure into the basement, they'd already started fluids because we've got clots, we've got some blood loss somewhere. We don't know how much, but let's get some fluids going because we might have to squeeze those in. So there's nothing wrong with giving fluid here, but remember the solution is blood, right? In the case of lost blood. Now, non-hemorrhagic, we're going to give IV fluids. Do we need to give blood here? There's not a reason, right? So same numbers, but we're not going to give blood, okay? Now, next question. Would we give something like norepi or phenylephrine to this patient? If you got your sheet with you, you can look at your sheet, see what find on your sheet, see what norepinephrine or phenylephrine does. Okay. You have a high heart rate and a low blood pressure. I love it that y'all both are trying to read that on your phone. I just love that. Huh? Those medicines do help with blood pressure, don't they?
For epi.
I asked about norepi or phenylephrine. What do they do? If you look at your sheet of paper, what do they do? How do they increase blood pressure? They're vasoconstrictors. Do we need vasoconstrictors here? Got to vote for no. Got other people hesitating. I don't know whether to answer or not. Feels like a trick. Okay, so Kara's going to go a little further with supporting you and saying you're going to clamp down and cause problems. All right. Anybody else have an idea about whether or not to give norepi or phenylephrine? Because the solution's fluids, right? Whether it's blood or what have they lost? Fluid or blood. So what do they need to treat the problem? You treat it with fluid or blood. Do we use an alpha or beta constrictor? No. No. You're going to make matters worse. What is it going to do to that heart rate? It's going to jack that heart rate up, right? It's going to clamp your vessels down. The toes are going to turn blue, and you're going to create problems. So, no, we don't want this. Okay? What about, I talked about last week, we talked some about Dobutrex and Milrinone, because somebody had a patient on Milrinone. Oh, there's another N in there. I only misspell when I'm at the board and someone's watching, right? What about Dobutrex or Milrinone? Arterial dilators, increase cardiac output. They help the heart squeeze better. You voting yes?
If the replacement's not working.
Oh, I didn't say anything about that.
We're going no.
I've not said anything about what if the treating the problem's not working. What I want you thinking about is the treatments. What do the treatments that she's got listed for you in these shock states, what do those treatments do related to your hemodynamics, right? So, Dobutrex and Milrinone, will they arterial dilate? Yep. Yeah. What's that going to do to your blood pressure?
Worse.
It's not going to make it better. And what's the Dobutrex going to do to your heart rate in this case? It's going to make it go up. Because the Dobutrex has got to try to improve cardiac output, and you're arterial dilating because that's the other action of that drug. So your heart rate's going to go up more, your blood pressure's going to go down, and you're going to kill this person. This is Donna. Donna would do this. Don't be Donna. You heard me reference Donna in class, right? Don't be Donna. I need a T-shirt that says "Don't be Donna." No, I hope none of you ever run into her. I really do. Yeah, unfortunately, you don't know her last name, right? So and I'll never tell. I will never tell. I hope you guys don't run into a former employee that I worked with, and they go, "Oh, I know who he's talking about," and they give you the last name. All right. So no, we don't want drugs. We don't want drugs in this case. The treatment for the hemodynamics that we see here. Do we need a swan for this? We don't need a swan to know that this blood pressure is bad and this heart rate's too high. And to know that this patient needs either fluid or blood, right? What do we need to know if they need blood? H&H, basically hemoglobin, right? And what do we need to know if they need fluid? Sodium, those things are going to tell you, all the things that tell you if they're dehydrated or not. Right? And then assessment findings, urine output, they may be vasoconstricted, their extremities may be cold, right? All of those things. Okay. Make sense? Mm-hmm. All right. So now we have completely covered the whole scope of hypovolemic shock. So y'all don't need that information anymore. You've got it locked in your brain, right? All right. I'm changing color just for fun. Okay. What do you want to do next? Neuro? Okay. Neurogenic shock. Have y'all talked in class about the events or things that can cause the kinds of things that can produce neurogenic shock? Okay. Spinal injury. What else?
Brain injury.
Huh?
Brain injury.
Okay. Traumatic brain injury.
Anesthesia.
Anesthesia. What else? You think of anything else? Cerebral edema. Which cerebral edema is it similar to? Well,
Please, medical alert, fall huddle, room 305. Attention please, medical alert, fall huddle, room 305. Attention please, medical
I
alert,
think that was
fall
my
huddle, room 305.
It's 305 is what that
Okay.
I'm saying.
Right.
It's so done.
So
Might get worse.
is cerebral edema different from traumatic brain injury?
Yeah.
Yeah. And it's also, now there is some overlap. What I'm going to put stroke here. Okay. There's some overlap in this area. And what I want to say there is the cause is different, right? And in fact, we should probably make stroke a thing all the time. But there are some similarities because there are two types of stroke, as you guys know, correct? Yeah. Yes? Have y'all talked about this? Have you ever talked about this? Okay. Boy, that's annoying.
Attention please, medical alert, fall huddle, pre-op, room 305. Attention please, medical alert, fall huddle, pre-op, room 305. Attention please, medical alert, fall huddle, pre-op, 305.
You're interrupting my jam. Okay. So traumatic brain injury
I think that's what
is, there's similar symptoms to these things, but the cause and the etiology is different. Okay. So when we say traumatic brain injury, what are we thinking about?
you want. Car wreck.
Car wreck. Somebody gets in a fight, gets hit in the head with a bat, right? Somebody falls at home, right? So within the realm of traumatic brain injury, there is an intracranial bleed, subarachnoid hemorrhage, or subarachnoid hematoma, subdural hematoma. Okay, so that depends on the location of where the bleeding as a result of the traumatic injury has happened. Okay? All of which have different ramifications, and one of which has a different urgency about it. So someone, while we're talking about some of these things, Google the difference between subarachnoid hemorrhage and subdural hemorrhage. Okay, somebody Google that. All right. So with neurogenic shock, have they lost significant blood volume? Okay, no. So it's not a volume problem, right? Do they have an obstruction in a major vessel or airway? No. Have they had a heart attack? And in this case, keeping them separate, not talking about someone who had a heart attack and then fell and hit their head. I'm not trying to complicate things. So we need to think clearly on these. So they haven't had a heart attack or some kind of heart damage. Are they septic? Okay, so you can have all of these things without having sepsis. Agree? So the cause in this case is a neurological origin, right? And as you can see with each of these, they involve the brain, or how does this affect the brain? Exactly. Communication from the brain to the rest of the body, right? So it all comes down to a brain thing, right? So what do you remember from talking about shock states that is the major problem with neurogenic shock? In one word. Okay, good. The major problem is regulation. Right? Somebody tell me what the major function of the thyroid gland is. Okay, regulate metabolism. What did you say, Brenda?
Stuff like temperature.
Okay, thermal regulation. Okay, where is thermal regulation? Now, the thyroid gland moderates it, but where is it ultimately controlled?
Pre-cortex.
Huh?
Pre-cortex.
Go lower. In the hypothalamus, in the brainstem, right? That's where, and the Hypothalamus regulates the thyroid gland to control temperature, thermal regulation, right? So if you have brain information that's not getting to the hypothalamus, to tell the thyroid to control body temperature, what could be a symptom of neurogenic shock? Hyperthermia and or hypothermia. So I'm going to use, have you heard this word labile? Yes? What is meant by labile? Fluctuates back and forth. So someone with neurogenic shock can have a labile temperature, right? You go in to take their initial temperature and it's 105. Oh shit, I need to get some Tylenol. So you go out and get Tylenol, you get distracted by something, you make it back in, because it's Tylenol, right? So you go back in there, you take a temperature again, and it's 95. That's a labile temperature. Okay? And it's not always that close together, but you get the idea, right? So you go from 105 to 95 in an hour, minutes, or whatever. So you have a problem with thermal regulation. That's the brain not being able to do the thing the brain does. What else does the brain control? Okay, please, let's get tangible here. Think about some hemodynamics that perhaps the brain or brainstem regulates. Anything else? Okay. So think about sympathetic and parasympathetic nervous system, correct? Is that a brain thing?
Yes.
That's central nervous system, right? So blood pressure, I'm going to put in here PNS, there's PSNS, parasympathetic nervous system, and sympathetic nervous system. Right? What else? Hormones, yes, which comes back to body temperature, but we'll put it on here. So hormones. What else? Okay, fluid regulation, which would be related to, well, no.
Consciousness.
Okay, consciousness. Yes, hard to write down here. The struggles of tall people. What about this one? Does the brain have anything to do with? Yeah. Okay. Do you remember when we were talking in respiratory, and I showed you a bunch of respiratory patterns, and I did some imitations of some of them. Do you remember a couple of breathing patterns I mentioned that were related to neurological things? They were toward the bottom. This is the definitive description. That's what Anessa was doing this. So you should know immediately by that what is meant. Anything coming back? Nothing's coming back? Let me draw a couple pictures and see if it refreshes your memory. So one of them would do that, and there was another one that would do like that. Nothing's coming back? Huh? Apnea is this. Where in the world?
Does it start with the C?
One of them does.
Cheyenne Stone.
Okay, which one? Which one?
Oh, I don't know. Oh, wait, I think the bottom one?
The bottom one is Cheyne-Stokes. Yes. Yes, this one is Cheyne-Stokes, where you have the escalation of the breathing pattern. So it's and then it repeats. Right, that's Cheyne-Stokes. And then this one,
What does it start with?
B.
There.
So there's something about your impulsivity that's appealing sometimes. Huh?
Oh. You play Hangman? Yes.
Bias breathing. So the breathing is clustered, but it's symmetrical in its depth and rest and intensity. So that's what I'm trying to represent here. So bias is clustered and then pause, cluster and pause. And I mentioned that these are associated with neurological injuries. Very common that you see these as the patients have trouble regulating their respiration. All right. So if you have someone who's breathing like this and they've had one of these things happen in a way that compromises blood pressure and heart rate, do we need to stabilize them? Are we going to need to secure their airway? Okay. Yes? Okay. So your patient actually didn't come up to shock, but they could have. They were on the cusp, right? So if they were breathing like this, we would need to stabilize the airway breathing circulation. Now, as we intubate them, we're going to put them on a ventilatory mode that supports them. Probably going to sedate them so that we can adequately control. Because if someone's not sedated, you put a garden hose in their throat and they're partially in and out, what's going to happen? They're going to try to rip it out. If you've got them restrained, they're going to buck the vent and you're not going to ventilate them well. Okay? So, when we talk about symptoms, now we have poorly regulated respirations. We've got to manage airway. We're managing breathing. Do we need to put them on a pressor? Just from the information you have on the board, do we need to put them on a pressor? Norepinephrine, phenylephrine, something like that. Kara's giving me a soft shake, like she's kind of wanting to commit, but yeah, I love you a lot, but I'm not ready to give you a ring. Right? I'll give you a ring, but not a date, kind of thing. It depends on what? What does it depend on, Neil?
Blood pressure.
Okay, remember we were talking about dysregulation, right? So, what would you want to know about this to know if you want to start a pressor or not?
It's stable. It's changing.
How about, let's break it down even more simply. What is it? What is that blood pressure? Okay. Now, Anessa had a patient today who had a prodrome of a seizure at a nursing home. Okay. Do you know what I mean by prodrome? It's kind of a warning sign that it's coming on. Some patients with epilepsy get what's called an aura. They just have a generalized sensation and they can tell it's coming. So she had this prodrome, which is a tremor. That was an indication, the family's just recently learned that's an indication that a seizure is coming. So she had a prodrome. They called the doctor or called the paramedics. Paramedics show up. They're getting her on the stretcher. Get her on the stretcher. She has a seizure. Okay. So she's had a neurological event. And there was a mention in the chart, as we reviewed the chart and asked her to look into some things, there was a mention of cardiogenic and neurogenic possible compromise. Or did they use the word shock in the chart? Okay. So no ifs. So in her case, when she came to the hospital, one of the things they put on her, in her, was what, Vanessa? Related to this.
It wasn't a swamp gas. It was,
Nope.
It was the.
I'm going to use red to help you, try to help you make the association. Was it what?
No, the. Oh my gosh. It's an art line.
Art line. All right. Not everybody gets art lines. Did your patient in ICU have an art line? Who else was in ICU? Not with hearts. Who else was in ICU today? Was you? Who else was?
That's it.
Oh, Anessa. So did your other patient have an art line? No.
Yeah. No, they
No. Okay. So And this had 2 patients, one of which did not have an art. Any of your patients have art lines? Y'all have like 4 patients today.
So it's only last
Yeah. They had several in and out. The guy with the pauses did not get an art line. Okay? Do we need an art line in him? He's having 15-second pauses. Do we need an art line? No, because when he's got a pulse, we can check a blood pressure and it was reliable, correct? Why does an art line make sense in this lady who had a seizure, several seizures?
Possibly compromised.
Okay, so if it were one of these things, what is an art line going to do for us related to blood pressure? Huh? Okay, it's going to be a very accurate. So that when we see, you push the button and the cuff goes off and you get 75/40. You're like, you go in there, jiggle it, push the button again, 120/80. Right? But if you have an art line, you're getting an average of every 6 heartbeats. Right? So you have a very consistent assessment, a very consistent hemodynamic assessment of blood pressure. Do we need an art line and anaphylactic shock? Please give me epi before you put in an art line. Right? Because the epi is the cure, right? This is a monitoring device. So if we have been monitoring the other things and we're starting to see a labile blood pressure, this is a good thing to tell us if we need what? Blood pressure medicine. Right? Because could someone with a traumatic brain injury be hypertensive? Yeah? Okay, so think about this. What's the number 1 cause of stroke? Okay, yes, lack of oxygen to the brain. I'm thinking like a diagnosis. You're absolutely right.
Like a clot?
Well, that's the occlusive.
Okay.
We'll come to that in just a second. This distinction in just a minute. What's the primary cause or contributor to stroke? Hypertension. Right? So could someone having either an occlusive or hemorrhagic stroke that puts them into shock, could they be hypertensive? Heck yeah. And so if they're hypertensive in their neurogenic shock, what are we going to treat them with? You've got some medicines on your sheet. Be specific. There's a specific one mentioned on your sheet. Nobody remembers? Y'all haven't memorized the sheet yet? Huh? Labetalol, and labetalol is what kind of drug? Beta blocker. Okay, so it's a beta blocker. There's another drug we could use to address, an IV drug we could use to address hypertension.
Propranolol.
Propranolol is oral, not an IV drug. Does metoprolol come IV? I have to look that. Maybe boluses. The one I'm thinking of is a.
Calcium. Nicardipine.
Okay, nicardipine can be sublingual, yes, and it is a calcium channel blocker. And we used to use it a whole lot. We poke a hole in the capsule and squirt it under the tongue. There's an infusion that's calcium channel blocker we could use. Hint, it's also used in the treatment of atrial fibrillation. No. 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 A D.
Oh,
Diltiazem.
Diltiazem. Right. So, in the circumstance where you have a stroke and we're trying to control blood pressure, right, then you could use a calcium channel blocker or a beta blocker, labetalol, the beta blocker, calcium channel blocker, the diltiazem. And a lot of providers are more comfortable using calcium channel blockers in this case, in the neurological environment. They feel like they get a better result than managing the beta blockers. But it's not wrong to use a beta blocker. All right? So, can you be in neurogenic shock and have a temperature of 105 and a blood pressure of 220 over 110? Can that be neurogenic shock?
Yeah.
Yeah, right? Because they're dysregulating, right? So we've got to treat those problems. Now, the ultimate treatment for the problem, if you have a stroke, is managing the type of stroke that it is. Okay, the first one's going to make a whole lot of sense. If it's hemorrhagic, that means a vessel in the brain has ruptured. Correct? Do you want high pressure on a ruptured vein? No, you do not. So we would definitely want a lower blood pressure in this case. If we have, and then so blood leaks into the sulci around the brain, right? Because that's the space it goes to. When you put blood into the extravascular space, what's going to happen next? Yes. So you will pull blood you will have blood there, yes, and it will create pressure. It's also going to do something else. It's going to further cause pressure. Cerebral edema. So blood is, right, it's not supposed to be in the extravascular space. So if you put blood in the extravascular space, for the extravascular space, is that going to be hypertonic or hypotonic for that space? It's going to be hyper, so it's going to pull fluid to it to try to dilute that blood. This is how, like when you get a bruise, the bruise goes away, right? The blood that's there draws fluid into that and dilutes it and ultimately reabsorbs. Same principle. So you're going to end up with a hemorrhagic stroke, you're likely going to end up with cerebral edema. Okay? Can you have cerebral edema from falling hitting your head?
Mm-hmm.
Yes. Can you have bicycle guy? You had bicycle guy, right? Cerebral edema. Right? He fell on his head. He had a traumatic brain injury. He didn't have an intercerebral bleed. He didn't have a subarachnoid hemorrhage. He didn't have a subdural hemorrhage. From the concussive injury, he had generalized cerebral edema. Can you get cerebral edema from anything else? Like meningitis. Yeah. Right. So something like that can produce cerebral edema. You have globalized swelling over the brain. You can't go get that fluid. The same way you can't go get it out of your foot when you have peripheral edema. Is that going to put pressure on the brain? Can that produce dysregulation? Could it produce high blood pressure? Could it produce low blood pressure? Right? So you can kind of see how these different conditions can produce different hemodynamics. All right, we're going to talk about medicines in just a minute. Somebody look up subarachnoid hemorrhage. What'd you find?
The difference. You're asking the difference.
The difference, yeah.
Subdural hemorrhage occurs between the dura and arachnoid layers, while subarachnoid hemorrhage occurs below the arachnoid layer and the cerebrospinal fluid space.
Okay. So arachnoid space. And what's the difference in the vessels that live in those spaces?
The subarachnoid one, it's like closer to the brain and a lot of cerebral arteries.
Okay. So this one, arachnoid arteries. means the dural space is more venous. Can you see a criticality between these two in difference, right? So one of these could constitute a surgical emergency. If you have a patient who comes in unconscious, extremely hyper or hypotensive, and they are temperature dysregulating, perhaps they have a wide pulse pressure. A wide pulse pressure is something like 150 over 30. Big difference between the systolic and diastolic pressures. It's a widened pulse pressure. This also tells you about tonal dysregulation of the vessels themselves and the cardiac structures. Okay? So you see on CT scan you have a subarachnoid hemorrhage. What do you think is the next step? Surgery. And what kind of surgery? Drill a hole. Drill a hole into that spot and let it out. Because these traumatic brain or intercerebral bleed, subarachnoid hemorrhage, and subdural hematoma are bleeds in a specific spot. Okay, there's a pocket of blood. And in this case, it's within the cerebellum itself. So it's in the middle of the brain tissue. In this, it's in the subarachnoid space. In this, it's in the subdural space. These two may not be surgical emergencies. This one, since it's arterial, especially if they're hypertensive, right? So if you have a blood pressure of you've got a patient with a subarachnoid hemorrhage, they're getting the OR spray, and their blood pressure is 180 over 90. What do you think a doctor might order on their to get them to get them taken care of before they go to surgery? Diltiazem, because it's going to lower the pressure and perhaps decrease the bleeding. And they may even say titrate to a blood pressure of 100 systolic, which sounds like you're really driving the blood pressure down, but we want the blood pressure down and pressure off of that bleeding spot if we can. Just like if you've ever had a low tire, you ever had a low tire and it gets down, you got pressure, everybody got pressure monitors in their cars, tell you the tire. So it gets down to about 25, the light comes on, and it never really gets lower than 25, right? But then you go air it up to 32, 34, and it starts leaking again. That's the idea. That makes sense? Okay. So, do we use norepi here? It's a good question, isn't it? Norepi or phenylephrine. Okay, so Alex is giving me a silent no.
At 150?
Huh?
At 150?
I'm not telling you what the blood pressure. I just asked you in general. Do we use this for the blood pressure for neurogenic shock? You may have. I don't know if you've seen this movie or not. Definitely, maybe, right? What does it depend on? What the blood pressure is. Okay, so if you have a patient who has this kind of temperature, their blood pressure is not labile, their blood pressure is 60 over 40. It's not bouncing all over, it's 60 over 40. Are these good drugs?
Yeah.
Yep. They're going to get blood pressure up. We need to support blood pressure to support the organism. That's the thing with shock. You support the thing that needs to be supported while you fix the problem. Okay? So in this case over here, do we need to support something before we get them to surgery or whatever? If they're hypertensive. Yes, in this case, we need to we support it by bringing it down because we know that if we keep letting the pressure stay high, it's going to cause more damage, right? And here, if we let him live here, that's going to cause damage, right? Now, if they're bouncing all over the place, we got a different problem. We may manage that with fluids as best we can. We may pour a lot of fluid. We may even give them albumin, right? So we're not having to give them liter after liter after liter. We can give them a volume expander like albumin to help hold that blood pressure up for a longer period of time or to keep it more stable. This makes sense? Okay. So are we going to use Dopitrex here? Do we have a pump problem? Nope. So I'll ask again. Are we going to use Dopitrex here? Use milrinone here? Use epinephrine here? No. Now, I will say, footnote, I will say I have had patients that are in severe neurogenic shock. I mean, basically with like a code for the whole shift. I had them on these drips, but in order to maintain a decent pressure, we had to add epinephrine. So I was giving boluses of epinephrine, but the patient was basically dead. So we were maintaining this patient until the family came to realize that there was no outcome. So at one point that particular evening that I had this patient, I said, these patients were very faith-based. And so I knew that I had to kind of get on their faith level. I said that I want you to understand, they were asking me about what I thought about outcome and if I've seen people come out of this. And my response to them was this, that you're familiar with the Bible, and there was one person that Jesus brought back to life, Lazarus. So if you're not familiar with the New Testament, there's a story of a friend of the family named Lazarus. He dies. Jesus comes 3 days later. He's at the grave. He says, "Come out." Lazarus comes out of the grave. And I said, "You're familiar with Lazarus?" I said, "These are the kind of people that Jesus came and put their hands on, and they walked out of the bed. Like right then. I don't see Jesus coming to do it in person. And I've not seen that happen." Right now, I wasn't being tacky or facetious. I was trying to speak their spiritual language. And ultimately, within the next 12 to 24 hours, I can't remember if it was on my shift or not at this point, but they finally, when the doctor came around for morning rounds, they basically came around to the notion. And that was after hours of me also explaining the pressure inside his head is greater than the pressure outside his body. So it's not getting in, no matter what I give. But that was neurogenic shock because he had a traumatic brain injury. I can't remember what the origination of that was. All right. So you notice that all these things have something in common, and that is injury to the brain itself, except for spinal injury, which injury to the spinal column. So you think of like a C4, C5, or C2, 3, 4 fracture. Nothing's getting to the body from the brain. So there's no regulation whatsoever. So you can see where we have to do our best to regulate the shock symptoms that are in front of us for neurogenic shock. Does that make sense? Okay. So in this case, there's no magic pill. It's not like we put them on epi or we put them on norepi or we put them on a vasodilator or whatever. All right. Good with neurogenic? All right, let's do obstructive, because there's not a lot of obstructive causes. But I bet you can immediately think of one. Huh? Okay, you can have obstructive pericarditis that could be so severe. Okay. Who said tamponade? Okay. Is tamponade restrictive?
What is a tamponade? I don't know.
All right. So tamponade is when you have. So that is the heart muscle itself. And as you recall, all organs have a visceral and parietal layer, right? Mm-hmm. That immediately is adjacent to the organ itself, and then this one is more adjacent to the other organs of the body, right? It's more external. So this is what we refer to as the pericardial sac, which is the space, or some people will say the potential space, between the heart muscle itself and that parietal layer, or visceral layer. Parietal layer being the one adjacent to the organ. The visceral layer closer to the other organs, or the viscera. Make sense?
Yeah.
Okay. So, if you insert blood into this, remember that the pressure in this space right here is much lower than any of the pressures in any of the structures in this area. Okay? Including the coronary arteries themselves. So if there is any kind of perforation in the heart muscle, the coronary arteries, the aorta, any of the pulmonary vein, the pulmonary artery, any of those structures, pulmonary capillaries, any of those structures that have a rupture or a puncture in them that allows blood into this space, which way is the blood going to flow? I just kind of said it. It's going to flow out of the vessel into the space, correct? Right? It's going to flow into this space. How does it get out? It doesn't. Okay? So the heart continues to beat, blood continues to flow, and what happens? Pressure begins to be exerted on the ventricles. So your ventricles begin to collapse and collapse and collapse. And if that happens, what happens to stroke volume? Right? So is this an obstructive shock? Yes. Right? So with pericarditis, what happens to the pericardial sac? It gets inflamed, and fluid can accumulate there, and we can call that would also produce a pericardial effusion. Okay, just this past semester, my mom went to. She has see the cardiologist because she has a Watchman, and she was going to need a pacemaker, so they decided to do an echocardiogram to make sure everything's stable from a cardiovascular standpoint. So she goes to see the place that does an echo, which is in Paragould, which is her cardiologist is in Jonesboro, but it's closer to her. So the technician is doing the echocardiogram. Mom's just been feeling, she's like, I just hadn't had a lot of energy lately. So the technician is scanning her heart, and the technician goes, "Oh, how you feeling?" Okay, you ready for this? 800 milliliters plus of fluid, pericardial effusion. Right? So she's like, "You're going to go to Jonesboro," which she did. She went to Jonesboro and she had it tapped, but she was fine. So the difference is that effusions can produce an obstructive shock, but they're not generally pumped the same as like a tamponade. Right? So there's not that kind of pumping action that pushes blood into the heart in a degree faster than it can compensate, or the sac can stretch. I have seen a pericardial effusion of 3 liters before. Dude's heart's huge. I mean, his cardiac silhouette was like a basketball in his chest, or a large head of lettuce. It's huge. But he was not in obstructive shock. But I'm not saying it couldn't happen. Okay? All right. So we've got these. Can you think of anything else?
Pneumothorax.
Okay. What kind of pneumothorax? A specific kind of pneumothorax?
Tension.
Tension pneumothorax. Why a tension pneumothorax?
Creates tension.
On what?
Heart.
On the heart, yes, but also more specifically on. Nope. There is tension in the thoracic cavity, but that's not what's causing the obstruction. Huh? The vena cava. So not just the vena cava. What are all the structures attached to the heart? So vena cava, so IVC, SVC.
Superior.
Yep. What about this guy? Right? Well, we're not to dissection yet. All right. So IVC, SVC, this is volume in, and this is volume out. Right? If you shift the heart 4 centimeters to the left, what gets obstructed? Flow in and flow out. So it is a cardiothoracic emergency. Agreed? It is a shock state. I mean, you really can't get more shocky than that. Agreed? Okay. So, question. Are we going to give epi?
No. Not yet.
Not yet. Okay. We're going to give Cardizem. Afraid to answer now, aren't you? No. Are we going to give nitro? No. Are we going to give Wtrix? No. Milrinone? No. Fluids? No. What is the cause of this shock? Huh? What is more? That's part of it. What is causing the tension? What's causing the obstruction? Air. Treat the problem, manage the symptoms. So if you have someone who is in obstructive shock from a tension pneumothorax, any of these drugs going to help you? What do they need? Needle decompression in a chest tube, right? Treat the problem, manage the symptoms. So same for tamponade. Are these drugs going to help tamponade? Depending on the degree of hypotension, you may see some drugs used, but what's the treatment here? Needle evacuation, right? Cardiologist has got to go in and tap that. Hopefully they're decompensating gradually and not an abrupt decompensation. But this can be done, I've seen it done at the bedside, where you have to. So.
Wait, is a PE considered obstructive or chronic?
Great question. Because we weren't finished with this list, right? So yes, tension pneumothorax. My next question was, anything else? You want to put it on the board? You want to go for it? You're going to step out there, put it on the board. What kind of PE? Severe, I'm going to say severe, or saddle, right? I mean, you can't get more severe than saddle. Now, the patient may not have if you remember the one I showed you in class, that image that had the slugs on it, or what looked like slugs, they didn't have the saddle because it wasn't at the right at the bifurcation. It wasn't here, like that. But if you recall, it was in 3 of the 4 lobes. So functionally, it was basically the same as a saddle PE. Agreed? Okay. So with a pulmonary embolus, a severe or saddle, where's the obstruction? It's not the aorta. Pulmonary artery. Okay, so the pulmonary artery is responsible for doing what? Receiving blood from where? The right ventricle. So it is ultimately responsible for receiving blood from the right ventricle, but also sending blood where? Well, ultimately, yes, but if you have a pulmonary embolus, can't what? Send it where? To the lungs, right? So if you have this big obstruction, it can't get to the lungs. So if no blood flow can get to the lungs, is that obstructed? Yes, it is. Is it a vascular issue? Yes, it is. Could it produce a shock state? Could it produce a situation where you cannot meet metabolic demands? Yes, because you can't get blood to the area it needs to get oxygenated. So you're basically suffocating someone from the vascular side, right? So, what's the treatment for this? Possibly, depending on where you are, thrombolytics. Okay? So if you're in Toadsuck, Oklahoma, right? Out in Toadsuck, there is a Toadsuck, by the way. It's actually Toadsuck, Arkansas, and it's down by Conway.
Yeah.
If you're driving from Conway to Little Rock, there is a sign for Toadsuck. Yeah. The other one I'll use from time to time is Lick Skillet, which is, this is kind of back up nowhere. So if you are in the middle of nowhere, hospital, are thrombolytics a good drug to give here? Yeah. All right. As long as there are no bleeding contraindications, right? So thrombolytics are a good drug. Do you have you given has Miss Rogers talked at all about thrombolytics? No names of thrombolytics. Okay, so I'm not even going to introduce names into your brain. But clot buster drugs, not blood thinners. Heparin, Coumadin, abciximab, Eliquis, no. Thrombolytics, tenecteplase, right? Alteplase, yes, they're clot buster drugs. They go in and dissolve clots like Drano. Okay? Yes. If you're in the middle of nowhere and you can't get into a lab. So basically what you've said here is dissolve the clot. If you walk into Mercy, didn't somebody with a PE, wasn't there a PE come in today? Did you have somebody with a PE come in today? Why had somebody with a PE? I'm just hallucinating? Okay. I just have a nursing instructor hallucination. It's okay. It happens after you turn 55. All right, so we can dissolve the clot or remove it. Embolectomy. So we can remove it. Now, here's the thing. Might we need to support something for this person before they get their embolectomy?
Yes.
The answer is yes. So what is going to guide our treatment for obstructive shock in the interim? They're at Siloam. It's going to take them an hour. Well, not an hour. They're in Lick Skillet. It's going to take 2 hours to get here because the helicopter's got to fly there and they've got to come back.
Yep.
Right? So that's good. Right? That's a good time. So they give thrombolytics in Lick Skillet because that's what they have in Lick Skillet. They've got thrombolytics. One bottle. It's been there for 6 years. I'm just kidding. All right. But it was a good year for thrombolytics. All right. So they give thrombolytics. In the meantime, they're waiting for the helicopter to come. What do we need to monitor? Heart rate, blood pressure, oxygen saturations, respirations, all the things. Monitor hemodynamics, correct? What's going to tell us which hemodynamics we need to monitor? The ones that go wrong. Right? Right? So, do we need to treat heart rate? That's a pretty open question, right? What's that going to depend on? how high the heart rate is or low the heart rate is, and what their blood pressure is in response, right? So if they're having bradycardia in response to this pulmonary embolus, what medication might we give them? Atropine. Atropine. So atropine in your notes says increases heart rate. Actually, what it does is it blocks the action of vagus. So it allows the heart rate to go up, unregulated by this parasympathetic nervous system. It doesn't actually stimulate the heart. Like epinephrine, beta 1 stimulates the heart. Atropine turns off the slowdown part of the heart, right? But still heart rate's going to go up. So if the patient's got a heart rate of 45 and they're hypotensive, we can try atropine, right? Does this make sense?
Yes.
Right? We want to manage the hemodynamics we need to manage that we need to support, right? Now, if your heart rate's 100 and their blood pressure drops, then what? Huh? Perhaps norepinephrine. We want to be cautious with vasoconstrictors. Why do we want to be cautious with vasoconstrictors and pulmonary embolus? Well, not moving the clot, but the clot is in a vessel. It has the potential for clamping down harder on those clots, right? So we have to be cautious there. So what would we want to monitor? So we start norepi. What would we want to monitor in conjunction with that? With monitoring blood pressure. Blood pressure start getting better. If we're concerned that other things might be getting worse, what are we going to monitor? Oxygen saturation and potentially PO2. If we've got a blood gas machine, we do gases, we can do PO2. Because oxygen saturation tells you how it's getting out here. PO2 tells you whether we're getting it in the bloodstream in here. You can see how those could work in conjunction here. Okay. Good with pulmonary embolus? Okay. There's another one we haven't put up here.
Physically crushed.
Well, yes, I'm thinking of something in a more generic term. Huh?
Sleep apnea?
Well, you're warming up. You're warming up. Something else that could cause obstructive shock. We have talked about obstructing the pulmonary arteries. That could cause shock, right? Could we obstruct something else related to the lungs and produce shock? What'd you say?
Bronchial?
Okay. I will accept that answer. Airway. Airway obstruction. Can that be an obstructive shock? Absolutely. So technically, could anaphylaxis from a bee sting be considered, because also fall in the obstructive shock category. So in this case, we're not talking about anaphylaxis, was referring to an evocation of your anaphylactic system, right? Well, we're evoking that anaphylactic response. So this is more a physical obstruction. So what could do this? Choking. So steak, right? Gum, penny,
Great. Waterboarding?
waterboarding. We're going to stay in the non-torture zone, just for now. Okay. So penny, grape, you get the idea, right? Marble, anything that obstructs the airway. How do you treat the cause? Remove the airway obstruction, right? Remove the airway obstruction. That's how you get it out. That's how you treat. So you see how with each of these, the treatment is a little bit different and may or may not involve medications. The medications depend, right, on what we need to support in the meantime to keep the organism viable. Okay. We're doing it. We may even still have time to talk about things. Okay. Huh? What's that? Was that a good thing, or? I've heard there's an interest in discussing that. ventilator modes? Is that going to be on this test?
Oh, yeah.
Okay. All right. Okay. Which one to do next?
Subject.
Septic shock. Okay. So, with septic shock, what is the problem? Infection. Now, a couple of us have had this conversation in the first couple of weeks. People can be septic without shock, correct? Okay. So, what is it that tells us we have sepsis to the degree that we have shock?
Hemodynamic valves.
Hemodynamics
Do not
do not meet
meet metabolic demands.
metabolic demands, and those hemodynamics are what? What did you say? Vasodilation. What else? Tachycardia. And we call it distributive because of what's related to the vasodilation. Have they lost any blood? Have they lost any fluid? Nope. What's changed to make their blood pressure drop?
Where the foot is at.
Huh?
Where the foot is at.
Well, the fluid's still in the same place, right? The vasodilation has changed the shape of the container. Okay? So what a pipe that was this big, right, is now this big. And the volume's the same. Do we have a volume problem? Nope. Do we have a vasodilation problem? Yeah. And that vasodilation is a direct result of the inflammatory process of having a infection in the bloodstream. So if it progresses left untreated, it progresses to the degree that it dilates unimpeded with those inflammatory cytokines, then you get a vasodilation that can cause a compromise in blood pressure. Okay? So, this is where the term distributed comes in, right? Because the fluid's still there. It's just not adequately distributed, okay? So, patient gets hypotensive and the heart rate elevation makes sense, correct? Okay, so are we going to use nitroglycerin on these patients? Not just no, but hell no. Are we going to use cardizem on these patients? Commit to it, Taylor. No. No, because cardizem is going to do what? Cardizem is a vasodilator, right? What's it used for? Its main purpose out there in the world is to treat what? Hypertension. We use cardizem to treat hypertension, right? We give it IV in a critical care environment because we have an acute hypertensive problem, right? So it's still a vasodilator, right? Whether we're treating hypertension or sepsis, it's still a vasodilator. Do we have vasodilation? Yeah, we don't need any more. So when I use cardizem, we're going to lose a beta blocker or labetalol? No. Okay, we're not going to use nitroglycerin. We don't want to open things up, right? So, what is something that has few side effects that we could use first? Well, yes, we're going to use antibiotics, right? Why are we going to use antibiotics? Treat the problem. That's why we're going to use antibiotics. Have to use antibiotics or the patient's going to die, okay? Because the infection's producing this, okay? All right. So let's move in the positive direction. What's another drug, something we could use that has little side effect?
More fluid.
Fluids. Do they or have they lost any fluid? No. So what is the purpose of using fluids here? Fill the pipes. Exactly. So if your bottle's not completely full, one attempt is to fill the bottle. Okay? So we could use fluids here, usually somewhere between, depending on the patient, 3 to 5 liters, right? And we're going to give them a bolus and then give the rest of it fairly quickly. And if we're not seeing improvement, then we know that fluids aren't going to fix this. Okay? So at this point, we've given fluids and we're still hypotensive.
Rest.
Okay, good. You're following me. You're tracking. Pressors, like what? Okay, good. Norepi. What else? It's another one I've mentioned a couple of times today. Phenylephrine, which you can buy in the pharmacy, just not IV. Anybody know what phenylephrine is? Neosynephrine?
It is another subtype of epinephrine. Fennel. It's actually a plant. Fennel. You're actually plant.
Is it apple?
You could come up with some bullshit.
It does.
When, I mean, that was, I
convinced you. I convinced you.
let that one play out just to hear where it was going.
Like secondhand embarrassment. It's hard to listen to.
I love it. All right. So, neosynephrine. Anybody bought nasal spray before? You get stuffed up? You go to the pharmacy, you can buy neosynephrine. Okay? Phenylephrine is that chemical. In this case, we're giving it in IV form. When you give phenylephrine into your airways, what does it do? Opens things up. When you put it in the vasculature, tightens things down. Now, you remember us talking last week about different hemodynamics, right? And the way they affect cardiac output. With sepsis, when you get this vasodilation, what it produces, the reason you get hypotension is because you get a drop in your SVR, systemic vascular resistance, because all the pipes are open, right? So if the systemic vascular resistance drops, tubes are wide open, what's the heart going to do?
Boom, 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 boom.
It's going to beat harder and faster, right? Because it needs to increase cardiac output to keep the pipes full. We talked about this last week, you remember? All right, so in sepsis, we have to increase the cardiac output to keep everything functioning. And what will happen with this is you will get a cardiac output of like 12. Cardiac output of 12 and a cardiac index of 6. You should, just from what little bit you know, you should recognize those as big numbers. Okay? It's not because the heart is so strong. It's because it's working so hard against so little resistance. Okay? So, do we want to give epinephrine to this heart? No? Why not?
Short acting.
It's short acting, but more importantly, what does epi do with the heart? Huh? It increases heart rate and it increases contractility. So we have plenty of heart rate and contractility. We don't need something telling the heart, just beat more. That's like telling the person who's already working 7 days a week, 20 hours a day, just work harder. It'll get better. We're not going to pay you more, but just work harder. You'll get more work done. It's not going to work, right? Only so much you can do in the time you're at work. So epi is out. Okay? If we want to treat a hemodynamic here, a specific hemodynamic, what would be the hemodynamic we want to treat? Yes, more specific, a more granular hemodynamic that we talked about last week. I've written on the board in green. SVR. That's where we want to target. Okay? That's part of the reason why I introduced it last week, showed how we can get to it, how it's a part of the hemodynamics. And it's also going to come in handy when we talk about cardiogenic shock, because it's the opposite. We're going to flip the script. So we want to target SVR. So what drugs are going to target SVR? Dobutamine? Nope. What does dobutamine do? Increases cardiac output, contractility. Do we have a problem with contractility? Nope. Nope. It also causes some arterial dilation. Do we need any kind of arterial dilation? No. Milrinone? No. We want to address the SVR. What drugs are going to address the SVR? You said it already, Kara. Pressors. You said pressors earlier. So pressors are going to address the SVR. Look at your sheet. Well, let me see. Maybe I'll just find it on here. Fine. Where is it? Dopamine. I know those drugs are on here. Lidocaine. Where is norepinephrine on here?
Right in the middle, underneath nitroglycerin.
Where?
Underneath nitroglycerin, like kind of towards the middle. Oh, sorry, here's my.
Maybe I don't have that sheet. Maybe that page is not with me. Okay. So, what does it say about the action of norepinephrine? Does it mention receptors? Okay. All right. So norepi is
Yes, it does, I'm sorry.
okay.
It's alpha and beta, adrenergic. I don't know how to say that word.
Adrenergic. Does it say alpha 1 or alpha 2? Okay. So it is a potent alpha activator. So when you activate alpha, I'm going to put two alphas and a beta. When you put a potent alpha in your bloodstream, it's really going to constrict the vasculature and not really affect the heart that much. All right. So yeah, you get some beta because if you put norepi on somebody, their heart rate may go up. Right. So if we just put it on you, your heart rate probably go up, but you're going to get more blood pressure increase relative to that heart rate. Make sense? Okay. Phenylephrine, however, is a more than epi. A more potent alpha has very little, if any, beta, except at very high doses. Okay. So this is a very specific drug to work specifically on the SVR. Now, what you're going to see is, as you have seen, you see norepinephrine started first. Okay? The reason for that, this is something you don't need to know, it's a rationale. Okay? When sepsis starts vasodilating, one of the hormones, or, well, I guess it's technically a hormone, one of the hormones that we start depleting is norepinephrine. It's a neurotransmitter that is present in our body all the time. It's a brain neurotransmitter. It's a vascular neurotransmitter. It's part of what helps us maintain our blood pressure, right? But we don't lose it because it's getting regulated in conjunction with the thyroid and the sympathetic and parasympathetic nervous system. But when you have sepsis that is producing this overwhelming set of chemicals that are saying dilate, 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 you start depleting norepinephrine. And so the wisdom is, well, let's give the thing that's getting depleted. And that's why we start here, right? And if this doesn't work, then we move to phenylephrine. And if these two don't work, we can add vasopressin. I can't remember if vasopressin's on your sheet or not. But we'll add vasopressin after that, which works through a different mechanism, but it produces vasoconstriction as well. Okay? So you see why we're not using the other drugs. Are we giving blood? No, only if we have some anemia and some blood loss for some reason. We're not giving blood. We tried volume at the beginning, right? But it has a limit. We don't just keep giving volume because we need to treat this, and we treat this with antibiotics. We manage it with this. Does that make sense? Right? Good? Got one more. Cardiogenic shock. So, based on the trends so far, when you have cardiogenic shock, what's the problem?
Pump.
the pump. So you have a pump problem or the heart. Okay? So, what hemodynamics are going to be affected here? We've got a pump problem. Preload, afterload, or contractility?
Preload.
If we have a pump problem, the hemodynamic that is the problem is contractility. Now, does that make sense why we might put a swan in somebody that's in cardiogenic shock? Yes, because we need, if they're really bad, we need to specifically monitor very granularly cardiac output and cardiac index. Okay? Think about what we were just talking about with sepsis. With septic shock, do they have a change in their contractility? I said a change, not a problem. They have a change in their contractility in septic shock. Commit to it. Yes, they do. What did I put on the board happens to their cardiac output index? It goes up, right? Now, different question. Do they have a contractility problem? We don't need to monitor that. If we support them and treat the problem, will we have an indication that our contractility is where it's supposed to be? Yes, we will, because blood pressure will improve and heart rate will come down. Does that make sense? We don't need a swan for that. And they already have infection. We don't need to take a tube and run it up to their heart and say, here, bacteria, here's your superhighway. Right? Make sense? So it's not the treatment for that. Now, for this, a swan makes sense, right? So we can put a swan in this patient because we want to monitor cardiac output index. Agree? Now, this is our problem, right? What are our symptoms going to be? When we think about cardiac output, what are our symptoms going to be related to? Okay, so yes, I was looking for a word that was a little more broad because you went there. So what does edema point to? Fluid overload, or in this whole cardiac output menagerie, preload. Right? So are we going to have preload symptoms? Yes. Pulmonary edema, peripheral edema, swelling, right? All those things? Yep. All right. So is there going to be anything else in the preload, afterload contractility that we're going to need to manage? What about this? Are we going to need to manage? I said manage. You need to manage afterload. Yeah. Okay. Why might we need to manage afterload? Okay. So with cardiogenic shock, what are things that you, in your mind, you think could produce cardiogenic shock? Myocardial infarction, boom, first thing that comes to mind. Particularly, what kind? STEMI, non-STEMI? STEMI, right? Kind of the first thing that comes to mind. So really, we're thinking of here, one of the first things is, like I've mentioned in the past, a BAMI, big ass MI, right? Because people can come in and have a heart attack, never get on the vent, right? They go to the cath lab, they get a balloon. Yeah, they had a pretty good sized heart attack, but they never get intubated. They never go into cardiogenic shock, right? So here's something to think about. You remember something a few years ago, a guy on the football field getting hit in the chest and then passing out, professional football player?
Yeah.
Remember that? Boom. He stands up after the tackle and then just crumples, right? Because why?
He got hit right when his heart was like.
He got hit in the heart,
Rhythm, yeah.
right? So he got basically like a pericardial thump, and it basically, in that moment, put him into shock, right? Until they got out there to do some things, he was in shock. Now, it may not have lasted long because he had a very quick response, but in that moment, was he able to maintain metabolic demands? No, because he crumpled in a pile. Okay? So, there are a variety of things. This is why we have airbags, right? Hitting the steering wheel could put you in a cardiogenic shock. Myocardial infarction puts you in cardiogenic shock. Trying to think of other things, but that's probably good enough. Now, if the heart has been damaged, your thumb put a whole thumb poked in your heart, puts you in cardiogenic shock. Might cause a tamponade too if you're not, Johnny on the spot, right? So if you have a huge myocardial infarction, big damage to your heart, what would you expect the ejection fraction to be? Less than 30. What did you say? Really crappy. All right. So we could say an ejection fraction less than 30. Right. So something like 10, 15, something like that. So the heart itself is contracting very weakly. Now that heart is still responsible for moving blood through the system in order for the system to stay alive. So, what are we going to have to do to make that possible? We need to increase contractility. What else? This will help the heart beat more efficiently if we increase contractility. Can you think of anything that will do that? Drug-wise? What'd you say? The one that you had?
Yes.
Milrinone.
Yes.
Okay? Milrinone, Will. Can you think of anything else? Dobutamine? And what did you say? What did you say, Alex? I thought you said something else. No, I thought you said something. You mumbled something. Huh? This is good, though. Dobutamine and milrinone, drug-wise, this is good. So those are going to improve contractility. Now, there's something else that they do to help improve cardiac output. There are two things you can do to improve cardiac output. Contractility is part of it. What's the other? Okay, you can decrease afterload. And not really vasodilating, but arterial dilation. Okay? And that's one of the effects of dobutamine, is it does arterial dilation, which helps. Again, I've used with you guys before with cardiac output, right? You've got so much weight to lift. If you've got to move in your workout 350 pounds, you could do it in 1 rep, or you could do it in 350 reps. Or you could do it in what? So 300 divided by 30. That would be 3 sets of 100, right? And then 50, right? There are a variety of ways you could move that, but you could decrease the weight to make it more efficient for you to move that much weight in that period of time. Correct? So we can make things stronger, or we can make the resistance less. Right? So you see how dobutamine and milrinone can do that. Would epi do that? Yes, but what? What's the asterisk but on epi? It's not about the vasoconstriction. It's about beta 1. The heart's going to be working harder. Do we want a beat up heart working harder? No, we don't. No, we don't. But we have to have some insight into cardiac output index. particularly if we're using these drugs. In fact, that's how we will adjust the dose to know if we're improving, is we put a SWAN in to get a cardiac output index, adjust the dose, see if that improves our cardiac output index. If it doesn't, adjust the dose from 2.5 to 5, check it again, right? This is a sequential thing you're doing every 4 to 8 hours or whatever, depending on how the physician prescribes. Now, for full-on cardiogenic shock, there is a mechanical intervention. Oh, I forgot to mention or ask, do we want to manage preload too?
Yeah.
Why?
Because if you don't detect that, that's more edema.
Okay, so if we have pulmonary edema, is that going to be a problem? It's going to compound our shock state? Yes, can it trouble oxygenate? Could we survive? Could we handle if it's just peripheral edema? Yeah, we could let that ride. Okay, so you can see how it depends. But if it's left ventricle, then we're worried about that. We want to unload the heart as much as possible. There's also a mechanical intervention, and I think you guys talked about this, or the intra-aortic balloon pump. Okay. So, in a nutshell, because I don't want to get lengthy on intra-aortic balloon pumps. In a nutshell, what an intra-aortic balloon pump does is it inflates when the heart is resting, right? So not when the heart's contracting. You don't want to push the heart against the balloon. So the balloon inflates when the heart is resting. This allows for whatever pressure is coming from the right side to more easily fill both the left atria and the left ventricle. Okay? So you get better blood flow into the atrium ventricle. Now, it deflates shortly before systole. So when if you've got a balloon inflated and then you deflate it, it creates, for the lack of a better description, a pulling action or a vacuum, if you like to think about it that way. So when the heart contracts into that vacuum, it's like it's sucking that blood around. So this weak heart doesn't have to squeeze so hard to get a better output. And we're going to cycle that with the heartbeat. That's what an intra-aortic balloon pump does. So it's a mechanical way of doing that. And additionally, when it's inflated, that's during diastole, that's when the blood flow is going to the coronary arteries. So you push more blood flow into the heart muscle itself, right? That's how it's going to help contractility. Make sense? Okay. All right. So you got shock states? Okay. We just have a few minutes. But I think I can give you an encapsulation of vent modes. And if you think about vent modes, it's somewhat intuitive. Okay? So, some of you have seen this on vents. CMV, if you've been in the unit, you see it on your heart patient today? Okay? You probably saw SIMV.
Yes.
Yes. Okay. SIMV. They may have come up on CMV. Continuous mechanical or controlled mechanical ventilation. Or manual, whatever. This means the machine is doing all the work. Okay. So if we have someone who's completely paralyzed and sedated, the machine's got to do everything. So I want you to tell me what that machine has to provide for that patient to be ventilated.
Oxygen.
Okay? It's got to provide O2. PEEP?
Yes.
Is that what you said? Yep. PEEP. You got to have positive end expiratory pressure. Why does this patient have to, why do we have to provide positive end expiratory pressure for this patient? So the lungs don't collapse because we've put a tube through the epiglottis, right? We've turned the epiglottis off. So we have to do PEEP because there's a garden hose there. Okay? So we have to have PEEP, positive end expiratory pressure. What else do we have to have? Huh?
Tidal.
We have to have a volume. Right? Y'all are missing the obvious one. That's here. Did you say?
No, I said that.
We have to tell that machine how often to breathe for this person, don't we? Yeah. So if we're taking over, we have to have these things. All right? A ventilator can do everything, something, or nothing. Some of you have seen this. It is called spontaneous, which means the patient is spontaneously doing the respiratory work. The machine's not doing anything except providing FiO2, right, and some atmospheric pressure, which you have to have because we have a tube in the throat. We have to do that much. So for spontaneous, we're going to provide an FiO2, which is your O2, FiO2, fraction of inspired oxygen. That means. So you have to have that. You have to have either PEEP or pressure support. One or the other, sometimes both. Usually it's 5 and 10, okay, or 5 and 5. This is kind of normal atmospheric conditions, okay? So what this does is it allows the patient to breathe through the tube as closely as possible as if they were breathing in this room without the tube, right? So if they were breathing in this room, would they be getting FO2? Yes, approximately 20 to 22%, right? Something like that, okay? Are they getting PEEP and pressure support?
Yeah.
They have an epiglottis and they have atmosphere, okay? So this just lets the patient do the breathing all on their own, if they're strong enough. And there's certain criteria that indicates whether they're strong enough to, first of all, do that, and then secondly, get off the ventilator. When they were talking about ventilators in class, did they talk about the criteria for extubation? Did y'all talk about that at all? Yes, in class you did?
We never talked about this.
Not in that, there's just like refer to this table for all the.
Okay, all right. Now, there are modes that are where the vent does something. And technically, in this mode, if the patient is conscious enough, they can do some of the work. So, if, for example, if their rate is set at 12, the patient could breathe 16 breaths a minute, and the machine will support that. And if the patient takes a deep enough breath, it'll let the patient do the work, right? Now, SIMB, which is what you saw, is a bridge to spontaneous. It's a step that direction. So, are you going to have an O2? Yes. Do you have to have a PEEP? Yes, because we still have a tube in their epiglottis. Yes. Do we have to have PEEP? Okay. Do we have a volume? Do they have a volume? Okay. Perhaps not. Okay. Do they have a rate? Okay. Did your patient have a rate? Yeah, they do. They do. The thing here, yes, they have a rate, but usually it's low, 6 to 8. So they have a low rate, which incentivizes the patient to breathe on their own. Okay. So when you have, so you think about, let's think about a rate of 6 because it's easy. So if the ventilator is set at a rate of 6, that means that it's going to deliver a breath how often? Every 10 seconds, right? So here we have a patient who's waking up from surgery. They're partially awake. Are they awake enough? I don't know. But we set the ventilator to go breath. What's going to happen inside the brain?
Respiratory drive.
Exactly. The brainstem goes, we need to breathe. Remember the good old chemoreceptors? CO2 starts rising, and the brain goes, we need to breathe. So hopefully around 5 seconds, the patient does on their own, right? And when the patient realizes they can do that on their own, they get a good breath, maybe they continue to take the next breath. So the actual patient rate, when you look, so remember, the right side of the vent's got the circles where the programmed rate was. The other side has actually what the patient's doing. So they may be set to 6, but the patient rate could be 10, 15, 18, right? Because the patient's initiating those breaths. When the patient initiates the breath, the ventilator is going to let them draw as deep a breath as they want. So if it's somebody like me and I draw 800 cc breath, mil breath, great, ventilator does nothing. But if they're weak because they've been in surgery, like your CABG patients, and they do kind of a, then it's going to go, wait a minute, we need a volume of 500. So it's going to give you the rest, right? It's going to help you with the rest of it. That's IMD. It's supported. So synchronized intermittent mechanical ventilation. So it's synchronized with what the patient's doing. It's going to intermittently give breaths if it needs to. If the patient continues to breathe 15, 20 times a minute, great. I'm going to sit in the background and let you do your job. And if they're breathing 15 to 20 breaths a minute and their volumes are good, so they're drawing 400, 500, 600 on their own, and their stats are great, they're following commands, they can cough, they have an intact gag, which means what? If they've got a cough and a gag, they can do what? They can swallow. They can prevent aspiration. In other words, they can protect their airway. If you have a cough and a gag, you can protect your airway, right? So now if they have a cough and a gag, they're following commands. Could I try them over here on spontaneous? Yeah, it's probably happening right now on your patients. If not, got extubated. So you saw them do this, right? They flip them over to spontaneous, let them go for how long? 20, 30 minutes. And then what would you need to know in 20 or 30 minutes? Patient's been intubated. We'll do this and then be done. So the patient's been on spontaneous for 20 or 30 minutes, and you're the provider. You have to decide whether you're going to extubate them or not. What do you want to know? So what? Okay, what does adequately look like, though? You got a nurse calling you to tell you what they look like to make a decision. What do you want them to tell you? SpO2.
Chest rise and fall.
Okay, what does the chest rise and fall look like? The work of breathing. What do they look like breathing like that? Oh, they're fine. They're calm. Nice and easy. What else you want to know? Heart rate. Respiratory rate. Breath sounds. Anything else you can think of that has to do with ventilation that you might have come across all the way back in adult 1 back in the fall. Specifically, CO2. So we're going to look at CO2. Is the CO2 in the normal range? Because if they're comfortable, respiratory rate's fine, they're not in distress, they're following commands, CO2's 59, you going to extubate? Not unless they're COPD or and they're normally 65, right? So you want to know if they're ventilating adequately. So that has to do with tidal volume and rate. CO2 measures that. How they look overall. How much work they're doing to breathe. Can they follow commands? Can they protect their airway, right? And those are the things that help you make that decision. Okay, we can pull the tube. That all make sense? Okay. I could definitely go more granular into ventilation because we can do pressure regulated volume control, pressure control ventilation, volume control ventilation, but I think that's more granular than what you're going to have on the test. So you kind of understanding what the major modes do and the settings you have to have for those modes based on what the mode is doing. Does that make sense, I think? Yeah. Okay. All right. Good day? Okay. We went over 10. Maybe I'll owe you 10 minutes.